Hello, everybody. Thank you so much for joining our first lecture series of the month. Dr. So is here and ready to present. He's going to start sharing his screen, but we'll give a couple minutes just for other people if they want to log on really quickly. But we are excited to have him. And if there's any questions, feel free to drop them in the chat or just interject if that's okay, Dr. So. But otherwise we are ready to go.
Okay, thank you, Olive. Can you guys hear me okay?
Yes.
Yeah. Okay, we'll give a couple minutes and then we'll get started. Okay, I think we might as well get started. So good afternoon, everyone. Thank you so much for the opportunity to present to you. My name is Dave So. I'm one of the new pancreas surgeons here at MCW, and I've had the opportunity to start my work here recently as a surgical oncologist, but also as a translational research scientist. So it's a huge honor to be able to present some of what's going on in the field at the leading edge of research. And more importantly, how MCW and our pancreatic cancer program is sort of charting the path forward with the tremendous support of the Laban Pancreatic Cancer Program, foundations like the Sina Magwitz Foundation, and most importantly, with patients and families who want to contribute to our learning. I have no disclosures. Um, I thought I'd just start with a little bit of introduction about myself. I was born and raised in Korea until I was about 11, and then we moved around quite a bit. I lived in New Jersey, Chicago, and then went to high school in California, and then went back to the East Coast for college. Then went to University of Michigan for medical school, followed by 7 years of general surgery residency at University of Washington in Seattle, and then most recently 3 years of fellowship training at MD Anderson in Houston. Um, Now, my parents don't really believe me anymore when I say I've really settled down in beautiful Milwaukee, but that's where we've been over the summer. And to tell you a little bit about how I got into surgical oncology and translational research, for the longest time, I really thought I was just going to do basic science research. But in college, after sort of emailing a bunch of labs in the area, I got connected with one of these labs, the very basic science. And they were looking at the bone marrow microenvironment and the hematopoietic stem cells and things like this. But I ended up working under a guy named Sid Mukherjee, who was a MD PhD. He was sort of finishing up his fellowship training at the time. And the long hours spent in the lab working with mice, doing experiments, really sort of provided a foundation for my sort of career in science. And then a couple of years into my working with him, he told me that he was writing a book. And I don't know if I'm sure some of you have heard about this book, The Emperor of All Maladies. It's sort of a history or biography of cancer. Um, and I had no idea that he was equally a brilliant scientist as well as an amazing writer. And I actually had a chance to work on some early versions of the manuscript over many conversations about science and about the history of cancer. And so I knew that I was going to be an oncologist. But when I got to medical school, I very quickly realized that surgical oncology or sort of treating patients with the potential cure is something that I really cared about. And so I've never really looked back since then, and it's been a long road, but a very, very fulfilling one. So now I know the title of the talk is very grand, latest advances in translational research and targeted therapies in pancreatic cancer, but this certainly is sort of an overly ambitious title that's something that could spend a week trying to sort of go through all of the sort of nuances. So I thought that for the next 30 or 40 minutes, I would just sort of tell you specifically how I got here from a scientific perspective, what specifically interests me most about translational research in pancreas cancer, and then talk about some of the new and emerging techniques that we can use to study it better, and most importantly, what sort of our immediate next steps are here at MCW. Now, one of my main areas of interest, and of course, many translational scientists studying the gastrointestinal cancers and how to best treat them, is the idea that the immune system can be harnessed to fight tumor cells. There's a lot of sort of underlying hypotheses and theories about the fact that cancer cells have to first overcome the immune system monitoring the body at all times um, for circulating tumor cells or cancer cells that don't look like normal cells. And much has been made in the past 20, 30 years with medicines, new kinds of medicines that allow you to amplify that immune signal to fight tumor cells. Now, while immunotherapy, if you've heard of things like checkpoint blockade and things like that, while immunotherapy has made incredible paradigm shifting improvements in outcomes in certain cancers like melanoma and lung cancer, we have really yet to see that kind of improvement or really any kind of effect in pancreatic cancer. And in fact, it's one of the cancers that are least, that have been shown to be least responsive to all of the sort of immunotherapy trials done so far. So over the past decade, a lot of work has been done to understand sort of the complex interplay between the pancreas cancer cells and its sort of surrounding tumor microenvironment. Now, I'm not going to obviously go through this complicated diagram, and I don't understand much of it myself, but it seems clear that something is a little bit unique in pancreas cancer in its ability to suppress and invade the immune response against the tumor cells in looking at how unresponsive they are to all of immunotherapy. So this was back when I was in Seattle, when I was about to start sort of doing some dedicated research years. And during my residency, I met a mentor named Vena Polarissetti, who was also a pancreas surgeon at University of Washington. And when I was sort of joining the lab, he had just started some collaborations with the Fred Hutch Cancer Center and some biotech groups in Seattle doing something called T-cell receptor sequencing. We can talk a little bit more about what that means. But basically, we were interested in looking in depth at the T cells. These are one of the main lymphocytes that are both in your circulating blood, but also thought to be in the tumors themselves. And these are the types of immune cells that can activate against tumor cells and cause direct killing of tumor cells. So that's obviously a very important target and one of the things that immunotherapy drives up in terms of its activity against tumors. So I was fortunate to have a bunch of already sort of preserved specimens from resection specimens of pancreas cancer. And so we actually had a bunch of these sort of preserved blocks from about 24 patients, all of whom had undergone surgery for their pancreas cancer. One of the first things that one of the newer technologies that we utilized during this time was something called multiplex immunohistochemistry. The long words don't really mean much other than to say that it allowed us to look on a slide. This is an actual patient specimen coming from the operating room, and stain it with all these pretty colors, but stain it with markers that sort of denote each specific type of cell. Now, this technology has advanced beyond recognition nowadays, and you can get hundreds sometimes of colors and different markers on one slide. But what it allowed us to do is it allowed us to look specifically within the tumor areas and see what kind of immune cells were present. One of the things that people had thought was that, and the sort of dogma at the time, was that the reason that immunotherapy doesn't work against pancreas cancer is that it's just an environment that is devoid of any immune cells to begin with. And there is this kind of dense scarring, kind of desmoplastic reaction around the tumor cells that people have found. And that suggested that maybe that's why immunotherapy doesn't work, because there are no T cells, for instance, to activate. What we found was that we actually did see a lot of T cells within the area. But when we looked specifically at things like CD8 T cells, those are the T cells that are doing the actual tumor killing, when they were in the areas around cancer cells, they were quite far away from the tumor. When they are not around cancer cells, they tend to aggregate more. This sort of suggested that there was some sort of, the tumor cells were secreting some sort of a signal that allowed them to sort of repel the T cells, to basically sequester them away from the tumor cells. Without getting into too much detail, we then sort of try to understand exactly which T cells were contributing to this kind of anti-tumor response. And this is one of the things that we took advantage of in terms of emerging technologies at the time. This is something called T cell receptor sequencing. Very basically, every T cell in your body, in your circulation, has to undergo a series of genetic recombinations. The details are not important, but what matters is that you have a unique population of many, many, many different, genetically different T cells that have this T cell receptor sequence. And this is what allows the body to find T cells that react to a certain kind of antigen. And once that reaction happens, once it latches onto something that it can bind to, that's when you get what we call clonal expansion, meaning that that T cell will then divide and multiply and make exact copies of itself. And so you would imagine that when the T cell is responding or activated against something like a tumor cell, there is evidence of clonal expansion, meaning that the same T cell with the same genetic makeup and the same T cell receptor sequence has been multiplying thousands, tens of thousands of times. So when we see that, we are able to sequence this and basically quantify the number of different kinds of T cell receptor sequences within the tumor environment. So we took this analysis and we looked at those same specimens and we did T cell receptor sequencing. And what we found was that if you took two sort of different areas of tumor, so basically totally different areas of the same tumor, and you run this kind of analysis, you find the same kinds of TCR sequences, meaning they're reacting to the same presumably tumor cell or something in the tumor environment, and that these are the ones that tend to be the highest in terms of their population, in terms of how many of them there were. And we found this across multiple patients. When you compare different patients, there's basically no overlap, meaning none of the purple dots here that overlap between two different specimens. What we also found was that, without again diving too much into the details, that there were multiple gene signatures, multiple T cell receptor sequences that ended up coding for the same binding sequence, meaning that there are many ways for the genetic material to rearrange to get a certain type of protein sequence in that T cell receptor binding pocket. And the fact that some of these had multiple, over 15, 20, 30 different genetic sequences, all coding for the same binding sequence, that was a very sort of clear suggestion to us that these T cells within the pancreas tumor were clonally expanded and seemed to be activated against something in the tumor environment, presumably something in the tumor cells. But when we looked at patients who had a lot of that sort of expansion and patients who did not have much of that expansion, there was no real difference in overall survival. This is after resection. The way you sort of interpret these curves is that on the y-axis here, this is overall survival. So basically you start with 100% patients, and this is 0 days whenever we're counting from. And then as you progress to the right, this is survival in days. And every time one patient or multiple patients drops um, from the group, meaning that they pass away due to disease, there's a little tick down. And so what you would want to see if you were trying to identify a patient population that had really good survival is that their line would be flat or nearly flat across the top, across about the 100% mark. That means that most of those patients survived out to 3,000, 4,000 days. You can see that these lines overlap and there really is no difference between these. So the question was, why is it that even though it seems like the T cells are there and they seem to be responding to tumor, why isn't that sort of correlated with any kind of difference in their overall outcomes? And we hypothesized that even though the T cells are there in the microenvironment, they're sort of shunted away, like I was showing you from the beginning, that they're sort of sequestered away from the tumor cells, which prevents their activation. These T cells need to be in contact with whatever they're targeting or trying to kill in order to have tumor effect. So I'll go through this relatively quickly, but given this hypothesis, we actually had a candidate for the mechanism by which this might happen. And again, this was done in sort of basic science animal mouse model work of pancreas cancer. But a group at Cold Spring Harbor had figured out that this sort of chain of reactions between these signals, these things called chemokines, and their receptors within this microenvironment of the tumor, this thing called CXCR4 was potentially responsible for repelling the T cells away from tumor. And they were able to show that by combining blockade of CXCR4, basically a drug that blocks CXCR4, and then combining that with immunotherapy, allowed the tumors to be killed after immunotherapy in a way that was not possible with immunotherapy alone. So I'll go through this real quick. The red cells here are the T cells, and then the white cells here are the cancer cells. This is in a mouse model. So this is negative control, meaning treating with nothing. The T cells, you can see, the red cells are kind of sequestered away. When you treat them with the immunotherapy, maybe there's a little bit of increased infiltration of the red cells, basically overlapping and kind of going closer to the tumor cells. This is the CXCR4 blocker. And the red cells, you can see, have now really invaded the tumor cells. And then when you combine them together, you see that there are a lot fewer tumor cells and the T cells are really everywhere within the tumor environment. So we wanted to see if we can sort of recapture this phenomenon in human tissues. And for that, we turned to a tumor slice culture model that the lab had sort of developed over many years across multiple tumor types. And this is sort of what gets to the idea of translational research. I think that there's a lot of sort of words thrown around, like in the title and in the chat as well, about, well, what does that mean? What does translational research really mean? And these kinds of projects, I would argue, are sort of the best examples of what translational research means. It means sort of taking the lessons learned from the basic scientists who work with animal models, who work on mechanism, who work on pharmacokinetics, and then you take those lessons and you apply it with sort of newer technology to human tissue and to human patient outcomes to see if the lessons learned from the bench, from these animal models or basic science research, can be translated into what it actually means for patients. This is a perfect example of this. these specimens would basically, these are pancreas cancer specimens. They would basically be taken directly from the operating room where the surgeon was performing the surgery. And then we'd evaluate it with the pathology team, and then a little piece of it that does not have to sort of do with the pathology and the clinical sort of need for the pathologist to look at everywhere under the microscope. There are areas of the cancer that are possible to be used without having any impact on the clinical diagnosis. And so we would take these straight from the operating room up to the lab, and then we sort of cut them into these little pucks you can see here. And then we would just put them on these collagen-coated membranes and then keep them in just sort of kind of regular cell culture media. And we would grow these for up to 9, 10, 14 days. And what we found was that this is a kind of a diagram. This isn't pancreas cancer, but this is the best pictures that I had. This is liver metastases from colon cancer. And for instance, you can see that we punch these little pucks, and then once they're on the vibratome, then we can put them into these little cultures. So what we found was that we could take these slices and then basically keep them in culture up to 9 days, and they maintain the architecture. These are microscope slides on day 1, basically right after they came out of the operating room, and on day 9. The architecture, meaning sort of how the tumor looked at the time of resection, is maintained, meaning that the cells are able to sort of survive that long. One of the other things that we looked at was, well, then can we test drugs on this platform? This is a very simple assay looking at something called cleaved caspase. It's an enzyme that activates when there's tumor killing, and so the red dots are suggesting that the tumor killing has not happened, and the tumor cells remain viable up to day 6. And we can test different sort of cytotoxic therapies, meaning that we can use drugs to then kill tumor cells and then have a readout, meaning that there's an increased cleaved caspase 3 signal, meaning that more tumor cells were dying after treatment with some cytotoxic drug. Now, most importantly for our research, we also show that the immune components that are present within the tumor environment at the time of resection were still there. So these are markers staining for, again, the CD8 T cells, some of the other things like macrophages and monocytes, and that we can actually see them kind of associating or around the tumor cells in the tumor environment up to day 6, up to day 9. So what this allowed us to do was basically have an experiment where we are using patient tumor specimens, and we're taking them into these little plates. And because each specimen, we can get many, many slices, we can treat these wells with different conditions. So that's exactly what we did. We sort of did the experiment that I showed you earlier, basically using negative control, the CXCR4 blockade, the immunotherapy, and then the combination. And long story short, there was the biggest increase in immune cells within this culture system after the combination therapy, and there was the most tumor kill with the combination therapy. We were actually even able to show on some other imaging techniques the same kind of thing that the mouse group showed, that after giving the CXCR4 blockade, the T cells migrated towards, in this case, the red cells, which are the tumor cells. And when you gave them in combination with immunotherapy, that it was able to mobilize towards the tumor cells. We can actually track this in live time. So we did like a 90-minute time lapse confocal microscopy, and we could see that after CXCR4 blockade, the T cells were getting closer to the tumor cells. So this is just sort of one overview of a project that I was personally very involved with, and we were able to publish, but it more serves as kind of a canonical example of what translational research can mean and how people are able to investigate why, the question of why pancreas cancer is so difficult to treat or has no effect with immunotherapy. In this study, we thought that potentially one of the factors that's putting the brakes on standard immunotherapy alone is this CXCR4 related signaling, and that by blocking CXCR4 with immunotherapy, that allows us to get the T cell mediated tumor killing that we would see in other cancers like melanoma. Now, in sort of true translational fashion, based on some of the work that we did, there was a group based in Johns Hopkins that performed actually this exact kind of idea, this phase 2 trial using the combination of CXCR4 blockade with pembrolizumab. Pembrolizumab is one of the most commonly used immunotherapies. It's a PD-1 blockade agent. And they performed a single arm phase 2 study, and they treated about 37 patients. And again, most of these trials tend to be, especially in the sort of kind of experimental setting, a lot of them tend to involve cohorts of patients who have already received a lot of chemotherapy and have resistant or recurrent disease. So I say that because even though they saw some interesting signals, including the enhanced infiltration of immune cells after the combination therapy, like we saw and like what the mouse model people showed, there was modest benefit or response. But again, this is really a little bit difficult to interpret because, again, these patients were highly resistant to chemotherapy to begin with. Having said that, the overall response rate for the 43 patients enrolled was about on the order of the disease control rate was on the order of 63%. The objective response rate was a little bit lower. This again was not sort of paradigm shifting by any stretch of the imagination, but at the same time, they were able to really show that this combination immunotherapy strategy could provide a benefit. So this is what I mean about translational research. This paper on the left, this is the mouse model work on which we based our clinical work, our translational work here. But that has made its way into providing the rationale for a clinical trial in actual patients. And I think the bridging the gap between the basic science and the clinical trial and shortening the time frame where you go from discovery in basic and animal models to the bedside. I think that is what translational research is, and that's what I'm very interested and focused on. So I know that was sort of a lot of information, and a lot of it probably not a little bit confusing in terms of the science. But having said that, I hope it gives a little bit of a sense of what kind of things can be done in this day and age with translational research, given sort of the right access to the hypotheses and the human tissue. Now, with the time remaining, I want to just touch on a couple of the newer methods of translational research that we have available to us. And I'll touch on a few projects that we're working on here at MCW that sort of gets to some of the next and newer questions. I'll talk about this modality that's gained a lot of popularity and use. This is just one platform, but it's something called digital spatial profiling, or sometimes called spatial profiling or spatial transcriptomics. Long story short, the way it works is that before we would have to utilize bulk sequencing, meaning you would take the whole tumor and you would sort of digest it and then get all of the RNA material or protein out of it. The RNA is indicator of what the cells within that tumor are expressing in terms of the various genes and proteins. And that has allowed us to gain a lot of insight into what the tumors are doing at the time that you get the sample. But unfortunately, it's bulk, meaning that the whole tumor is thrown in there. And as I've shown you before, the tumor environment, especially at the time of resection, is not just the tumor cells, it's the tumor cells, the immune cells, the stromal cells, the fibroblasts, There's lots of different components to it. What this technology that's relatively new has allowed us to do is basically take a slide just like the ones that I've shown you before and apply these probes, basically little tags that allow binding to specific RNA sequences, and then basically run that kind of transcriptomic analysis, but this time on a slide. And so this is one of the experiments that I did at MD Anderson with my PI at the time, John Wargo, but we were looking very interested in a couple of other GI cancers and their ability to respond to immunotherapy. And one of the things that we did was this kind of digital spatial profiling experiment where we were able to first identify the different components. And here we have the tumor cells here in green, the stromal cells here in black, and then the immune cells in yellow. And we're able to look at what those types of cells are expressing in terms of their RNA and protein expression separately. So it's not taking it all together. We're actually able to look specifically at what the immune cells, for instance, and the stromal components are doing at the time of resection. And so we developed some signatures that were quite sort of new and novel that seem to correlate with much improved survival. This is not in pancreas cancer, but this is in small bowel neuroendocrine tumors. But I put this up here just to kind of highlight that this is the kind of technology that is available to us now in 2023 and 2024. And furthermore, and we'll get back to why this is important, this is a very high throughput and powerful way to do this analysis, because this is now looking at one slide. This is something called a tissue microarray, or TMA. These have been around for decades and decades, but basically it allows you to put many tumor samples. So this has about 45 different patients worth of samples onto a single slide. And then we can run this analysis basically once. It makes it very time effective and cost effective. But you can still get a lot of information from each of these cores. That's those zoomed in. And these are different patients, different areas of their tumor, but still getting that information. So going back to our original experiments, having this kind of tool, can we determine the transcriptional differences specifically within the T cells, and more importantly, within the T cells that are close to the tumor cells versus the T cells that are away from the tumor cells? And this kind of technology allows us to do these kinds of things. We can also look at the fibroblasts and the other things that are producing the other side of the signals, like the CXCR4, and whether there is really, truly that kind of activation going on between CXCR4 and PD-1 blockade. So looking forward, there's been a lot of work that's been done over the past 2-3 decades, fine-tuning our understanding of anatomy, especially as it pertains to resectability at the time of diagnosis and after neoadjuvant therapy. Dr. Evans, the chair of surgery here, and Dr. Katz, my boss in Houston, were some of the earliest groups to describe these different types in terms of whether they're resectable, whether they're borderline, meaning there's a lot of contact with vascular structures, or whether they're locally advanced or unresectable. And a lot of the trials that have been performed, especially in surgical patients, patients with potentially surgically resectable disease, have focused entirely on anatomy. Because to be honest, we didn't really have much in the way of other tools to try to predict who would respond to a certain therapy and who would not. But as we move towards the future, our sort of understanding of the biology using those means like I've shown you before really have to drive and be a critical part of the clinical trials, rather than just going by the CT scan before the treatment and the CT scan after treatment. There have been many different types of these sort of trials that have that are ongoing, and some which have shown interesting results. Things like the Apollo trial, which demonstrated that people with a certain kind of genomic mutation within their tumors is able to respond better to a certain type of chemotherapy as opposed to the conventional type like FOLFIRINOX. And then there are other ones that are looking more at sort of transcriptional profiling, like the ones that I've shown you before. Now, I'll end by talking about some of the things that we're most excited about here at MCW. Now, I've only been on staff here for a short amount of time. I started in October, but already I've been able to sort of get quite involved with the surgical oncology tissue bank in the Levant Pancreatic Cancer Program. So just to talk to you a little bit about this, this is a tumor banking system that Dr. Evans, along with some of my predecessors, Dr. Sai, and maintained by Mohammed and Nikki here in the Department of Surgery. It allows for us to be able to bank patient biospecimens, meaning not only the tumor resection specimens, of course, those are very valuable to us, but specimens like blood at the time of diagnosis, blood during treatment with chemotherapy or radiation therapy, potentially biopsies down the line when there is a concern for recurrence. And so we have over 8,500 specimens that are banked from over 3,000 patients contributing. This is not all pancreas cancer, but about half or 60% are pancreatic cancer. And so what we've been able to look at is something that affects people of Wisconsin a little bit more than everyone else in the United States. As you all probably know, the incidence of pancreas cancer within Wisconsin is on the higher side. It's among the top 5 or 6 in the country. And so this is a unique, somewhat unique problem that affects the people of Wisconsin and Milwaukee. And we want to try to utilize the tissue bank here at MCW to answer some of the important questions about how we can optimize therapy and outcomes. So from this tumor bank, I took about 1,100 patients who had pancreas cancer, who had completed neoadjuvant therapy. I'll just review real quick. Neoadjuvant therapy refers to the therapy that you get prior to a planned operation. So in general, people who present with metastatic disease or stage 4 cancer, they have cancer in the liver and things like that, they are not candidates for neoadjuvant therapy. They just get systemic therapy. Neoadjuvant therapy can take the form of chemotherapy. Regimens that you've heard about, I'm sure, are things like FOLFIRINOX or gemcitabine-based therapy, and also chemoradiotherapy, basically radiation to that area. So out of these patients, we narrowed our list down to about 700 patients who had final sort of resection of their tumor after neoadjuvant therapy and did not have any metastatic disease. Now, this again is one of those survival curves that we've looked at a couple of times. I'll explain what this is. So as I talked about before, the group that is doing well has a line that's the flattest. So this is over months from surgery. So for instance, this is 120 months. That's 10 years out from surgery. This is a proportion of the group that's surviving. Now, if you look at the 10-year mark right here, that's above 50%. And this is just separating out these patients by thirds, by tertiles. There's a lower third, middle third, and the top third. It's very clear that there is a subset of patients who do extremely well, even though a lot of the therapy that they got and a lot of the disease that they had up front look exactly the same on paper. These sort of exceptional responders were something that was really interesting to us. And so I looked a little bit further. One of the things that predicted this incredible response, and again, this is out to 10 years, 75% of this group has survived up to 10 years. This is something called PCR, or pathologic complete response. Now, as I said, all of these patients had received neoadjuvant therapy of some sort. So when they do the resection, the pathologist can tell us or estimate how much response there's been to the therapy, how many sort of tumor cells, what percentage of the cells in the area are tumor cells, do the tumor cells look viable, Or do the tumor cells look necrotic and apoptotic and not very active? This special group of people, PathCR, means that they were not able to find any tumor cells that were viable within the tumor resection. So presumably they had an incredible response to therapy, but more importantly, it's not just that you had the pathologic complete response at the time of surgery, it's that these people then go on to have incredibly long and durable progression-free survival, meaning no disease coming back up to 10 years and beyond. I won't get into the weeds of this, but all that is to say, when you look at patients who have pathologic complete response versus everybody else, and you want to ask, well, is it just because these patients had some sort of characteristic before they started their therapy that would make them sort of better candidates for longer survival? Things that would be obvious, like size of tumor. One thing that would be incredibly important to know, whether resectability, like I talked about before, whether something is clearly resectable or something is on the veins or on the arteries and requires a lot of work and looks a lot more infiltrative, whether that has anything to do with it, the location of the tumor, even the presence of lymph nodes that were detectable on CT or MRI at the time of diagnosis. None of these factors could predict in our database pathologic complete response. Because, and the way you read this is that basically, if any of these bars cross this red line, that means that there's basically no statistically significant factor. Now, when we looked at a couple of these samples separately in some of the work that Nikki Lytle, our staff scientist, had done as well, when you look at those people who have very late or no recurrence at all, these people in their blood had certain cytokines. The names of these are not that important, but what is important is that they seem to be associated with anti-tumor immunity. And this is at the time of diagnosis. So before any treatment has happened. And this is of extreme interest to us because if we can find factors that clearly we are not able to find right now with using standard metrics, even radiology, labs, patient demographics, patient factors, if none of those things can predict who's going to respond the best, but we have a signal that suggests that maybe people with pre-existing increased signatures of anti-tumor immunity, that these are the people who are going to have the best response to chemotherapy and chemoradiation, and also have the longest duration of progression-free survival. That's something that would be very, very worth investigating and trying to understand better. And so the work that is going on now is to take these specimens from the blood of patients who had late recurrence versus early recurrence, patients who did really well versus patients who didn't do very well after surgery, match them basically to have the two groups look exactly the same on all the things that we would normally see in terms of their age, their comorbidities, the tumor size, location, all that stuff. And then do some of those other translational techniques I talked about, like RNA sequencing at a single cell level, to try to understand what is driving this enhanced anti-tumor immunity signal, what cells that are in the circulation are responsible for this signal, and most importantly, figure out some way to either test it in a meaningful way, or more importantly, be able to find a target to intervene on with some sort of drug. This kind of taking the bench research to the bedside has always traditionally been done, and it's called translation, but in translational research. But I think what we have the ability to do now, especially with the resources here at the Pancreatic Cancer Program and the Tumor Bank, in addition to the tools that I've tried to highlight that we have available this day and age, I think it allows us to make this a more circular process and accelerate the ability to go from something found on the bench from a mechanistic standpoint to benefiting patients that we see today. A lot of work has been already done with Dr. Evans and the Pancreas program with this recent publication in gastroenterology. I won't go through all of the details, but suffice it to say, there's been a lot of work done here at MCW that I'm trying to sort of move forward along with Mohammed and Nikki and others in our department to bring this accelerated translational research to MCW and continue to grow its impact on patients of the future. So with that, I'll stop there and take any questions, and thank you very much for your attention. I see actually Elizabeth's question about the BRAF mutation targeted therapies, and that's a great point. I haven't done any specific work looking at that, but one of the things that we also have access to, and this I didn't really touch on too much, as many of you know, now even at time of diagnosis, but certainly after the tumor comes out at the time of surgery, a lot of these samples are getting sent for genomic sequencing of one sort or another, things like Tempus or Signatera and these kinds of things. Basically allows us to really understand things like BRAF mutations. That's a little bit less common than something like KRAS mutations, but KRAS mutations are present in about 90% of all sporadic pancreatic cancers. And recently, much work has been done to try to bring some of those specific KRAS inhibitors to market with some very promising signs of success. There haven't been any major multi-center phase 3 trials within pancreas cancer, specifically looking at the impact of KRAS inhibitors, but that's certainly something that's going to come down the line. Well, all that is to say, the tumor bank also allows us to have access not only to all the data that I showed you before, but also to the Tempus genomic material. And so one of the directions that we are sort of heading, and this is a little bit more of a longer term project, is to try to assess what factors, not just the named mutations that we always sort of see, what specific genes or transcripts within the tumor profiling can correlate with things like exceptional response to neoadjuvant therapy or pathologic complete response within our database. I think we have a very unique opportunity to do that, both because of the infrastructure that the Pancreas program, Dr. Evans and others have set up here, because of the engagement of the patients and families that we see at MCW and in the Wisconsin area that are so dedicated to providing consent, providing tissue, that it's basically just some massive resource that we just have to mine. One of the other questions, is there a study or trial drug for pancreatic cancer patients living 4 years and longer after orbital surgery? And that's a very good question. You know, one of the things that, and if you join us for one of the other sessions during the month, Dr. Mandana Kamgar, she's one of the medical oncologists and an excellent researcher and translational scientist herself. She and Dr. Evans have created one of these trials that kind of alludes or gets to that question. It's called the Protect Panc trial. There is a question of whether we know who would benefit from additional targeted therapy based on high-risk features at the time of diagnosis, at the time of resection. So these are patients who have undergone all the things that we've sort of given them in terms of neoadjuvant chemoradiotherapy, they tolerated the surgery, there was no metastatic disease, the margins were negative, and for all intents and purposes, while we're surveilling them, they would be considered disease-free. But to that point, we're a little bit, it's obvious that we are a little bit behind the 8 ball in terms of determining who is going to recur and who do we need to consider more frequent surveillance and also more targeted therapies down the line in the adjuvant setting. And so the Protect Panc trial enrolls patients after surgery who have certain high-risk features, things like the presence of lymph nodes on the final pathology, for instance, and allows them to undergo surveillance in addition to just CT scans, things like circulating tumor DNA and things like that. And most importantly, allows for them to undergo therapy when there's some evidence of recurrence uh, in a more sort of accelerated way. That's one way that we're answering this question about how to address patients who are living without any recurrence, but who may be at higher risk. As far as I know, there aren't any real trials for patients who are living 4 years, 5 years, 6 years, and longer after open surgery, to be honest. And I don't have to tell this audience that is unfortunately rare, but as you can see in our database, they are a group of patients that we have, Dr. Evans and the group have cultivated here over the years, and we need to learn as much about them and about their biology and what determines that good outcome. Another question from Elizabeth, this is a great question again about EUS, so endoscopic ultrasound and RFA, radiofrequency ablation, to get the immune system to respond to pancreatic cancer. So I actually had a chance to talk to Dr. Chris Ray. He was one of the surgeons who was actually involved in this trial along with some of the gastroenterologists. So by happenstance, I actually have heard a little bit about this. The idea is that you're trying to basically, in a similar way as radiotherapy, for instance, but probably in a much more inflammatory way, trying to cause some sort of local effect in the tumor and cause tumor cell necrosis, and which would then drive local inflammation and potentially get to more antigen presentation and more systemic effects. Basically, they do an endoscopic ultrasound, and then they go on with a little radiofrequency probe. These are probes that are used mostly for liver tumors these days, to basically usually either using radiofrequency, or a lot of them use microwaves now, basically superheat the end of the sharp needle. And because they can place it under ultrasound guidance, it's thought to be reasonably safe. I remember talking to Dr. Ray about the obvious drawback to this approach, which is that you could get major pancreatitis. People get pancreatitis just from biopsies. So imagine trying to cook the tumor with the tumor intact. So that would be one of the things that would be that they're looking at very closely. Anecdotally, he thought that maybe there wasn't as much pancreatitis as one would think. I think the idea and the sort of hypothesis behind it is very powerful, but I don't know where they're at in terms of their preliminary or translational data in terms of the immune system and the response to pancreas. But it'll be something that I'm sure we'll see in the next few years published somewhere. There's another question by Shelley. If I was not treated at MCW, is there a way to submit a tissue sample of my tumor for MCW's research? I am an 11-year pancreas survivor after Whipple, chemo, and radiation. First, congratulations, and congratulations to all the patients and survivors who are on the call. For sure. I mean, it's a lot that we throw at all of you, and to get through it and to have enough sort of free time and interest to be on this call at 6 p.m. It means a lot to me, and it means a lot to all of us. I don't know if there's a way to submit tissue, but I will find out, because I think you know how special that is, and I'm sure that there's a way that we can do it. So Shelly, maybe I'll catch you offline and maybe get your contact, and I'll figure out whether there's a way to do it. We would love that. I think these are all phenomenal questions. So thank you so much for your attention. Thank you for these incredible questions. I think you guys know a lot about this disease, and it's this kind of engagement that allows us to do the work that we've done, allows us to plow forward with some of these sort of newer ideas, projects, and the whole point of it is to actually benefit the patients that I'm going to see, that Dr. Evans is going to see a year or 2 years down the line. So thank you all so much for your attention. And Olive, if there's anything else, let me know. But otherwise, I think they've heard enough of me today.
Thank you so much for your presentation, Dr. So thank you so much to everyone that joined. This is just the first lecture series of many more that we have through this month. So stay tuned. Tomorrow we have Dr. Evans, same time again from 5 Central to 6 Central. All of our sessions are being recorded, and once I'm assuming the month is over, we'll figure out where they can be accessible for all of you guys. But again, thank you for everything, and everyone have a great evening.
Thank you all.
Thank you.